Hello students, I welcome you all to OBGYN with Mackler. So in this session we are going to deal with about Kallman syndrome. Okay, so as we have discussed in the previous module, we have discussed about primary amenorrhea and we have divided that into with uterus present and uterus absent. In uterus absent there are two conditions, Mullerian agenesis and androgen insensitivity syndrome. Mullerian agenesis is 46XX and androgen insensitivity syndrome is 46XY. Okay, so then we moved to the next topic, that was primary amenorrhea with the uterus present. In those we have discussed about cryptomenorrhea in the last module, and now we are going to deal with the next topic, and that is going to be about Kallman syndrome. Okay, so let's discuss about this syndrome. Like as we all know, there are certain genetic disorders like Turner syndrome, Swyer syndrome. There is a syndrome known as Kallman syndrome. Okay, so this Kallman syndrome, the major problem is that hypothalamic failure. So hypothalamic failure is the major problem in the Kallman syndrome. As we have discussed in the previous session, for a proper menstruation to happen, the first stimulus has to come from the hypothalamus. So the gonadotropin releasing hormone has to be released from the hypothalamus. Now this GnRH will act upon the anterior pituitary. So when this GnRH will act upon the anterior pituitary, FSH and LH will get released. What is FSH and what is LH? FSH means follicular stimulating hormone and LH means luteinizing hormone. Am I clear? Yes. So this FSH and LH will act upon the ovary. So from the ovary we know that there are two kinds of cells. So one is going to be the granulosa cells and the other is going to be the theca cells, right? Yes. Now what will this granulosa cells do? So this granulosa cells will secrete two things. One is estrogen and inhibin, right? Inhibin B. This inhibin B will have a negative feedback on FSH and estrogen will also get released from the granulosa cells. So this main function of estrogen is to proliferate the uterine endometrium. Am I clear? Yes. Now, when the estrogen is present in a concentration of about 200 picogram for a period of about 48 hours. So when the estrogen is present in a concentration of about 200 picogram for 48 hours, it is going to have a positive feedback on the luteinizing hormone. So this luteinizing hormone will have three functions. One is going to be, it will luteinize the granulosa cells and releases the progesterone. So the major function of progesterone is to support the uterine endometrium. Yes? Okay. Other thing is that it will also produce androgen from the theca cells. Okay, so this androgen will later convert into estrogen with the help of the enzyme aromatase. Is that clear? Yes. And then when the LH surge is going to happen, that is the meiotic division which is going to be arrested in the diplotin stage of the prophase, when the LH surge is going to happen, it will resume actually and ovulation is going to happen. Ovulation is the process where the primary oocyte will get converted into the secondary oocyte. Is that clear? Yes, and all the follicles will get converted into the corpus luteum. So in ovulation, primary oocyte will be converted into secondary oocyte and corpus luteum will be formed. Is that clear? So this is the normal menstrual cycle. So in Kallman syndrome, what is the major problem? So in Kallman syndrome, the major problem is about the hypothalamus. There is going to be hypothalamic failure. So because of this hypothalamic failure, we all know that the gonadotropin releasing hormone is going to be released from the hypothalamus. Is that clear? Yes. The GnRH is going to be released from the hypothalamus. Yes. So if the hypothalamic failure is going to happen, then this GnRH will never be released from the hypothalamus. Once the GnRH is never released from hypothalamus, it can never act on the anterior pituitary and release FSH and LH. So ideally, in patients of Kallman syndrome, because of this hypothalamic failure, which will lead to decrease in GnRH release from the hypothalamus, therefore, the LH and the FSH levels will be low. Is that clear? LH, FSH levels will be low because there is no stimulus coming from the hypothalamus, that is GnRH. So when the GnRH is going to be decreased, it will never act upon the anterior pituitary. Therefore, the FSH and LH level is going to be low. Yes. Okay. Once the FSH and LH level is going to be low, then it can never act upon the ovary and release estrogen and progesterone. So when the estrogen level is going to be less, the estrogen level is going to be less. So once the estrogen level is going to be less, we all know that estrogen is very important for two things. One is that for the development of breast. For the development of the breast, estrogen is very important. So therefore, breast is going to be absent at puberty since the estrogen is going to be less. At the same time, we all know that at puberty, breast development and the pubic and axillary hair development is going to happen. So the breast development will depend upon the estrogen and the pubic and axillary hair development will depend upon the androgens. We all know that in female, androgen is going to be present in a level which is supposed to be present in a female. Is that clear? Yes. So here, when the FSH and LH is never going to act on the ovary, it will never release estrogen, it will never release progesterone, and when it is not act upon the ovary, it will never release androgen as well. Is that clear? It is not going to release androgen also. So because of that reason, the pubic and axillary hair development is also going to be very scanty. So only scanty pubic and axillary hair is going to be present. On the other hand, the breast development is going to be absent because the estrogen level is going to be less. Since the LH and FSH will never act upon the ovary, so the granulosa cells is never going to release estrogen. So actually the level is going to be very less. Is that clear? Yes. Okay. So now let's talk about the external genitalia and the internal genitalia. So when discussing about the external genitalia and internal genital organ, see, everything is normal. The karyotype is going to be normal in such females, right? So we all know that the female karyotype is 46XX. So when 46XX is present, then therefore the internal genitalia has to be a female internal genitalia. And when the Y chromosome is absent, when the dihydrotestosterone is not going to be present, therefore the external genitalia is also going to be a female external genitalia. The only thing which requires consideration here is that the uterus in such female is going to be hypoplastic. Why? See, we all know that for the proper growth and proliferation of the uterus, we need estrogen. So estrogen is the one which will bring about proliferation of the uterine endometrium, thereby resulting in increase in size of the uterus and proper development. So when the estrogen level is going to be very less in such females, therefore the uterus is going to be hypoplastic, underdeveloped uterus. So that is why estrogen is hypoplastic in patients with Kallman syndrome. So we have discussed about breast, pubic and axillary hair, LH, FSH, internal genitalia, external genitalia and everything. Okay, and what is going to be the gonad in this female? Since it is 46XX, therefore the gonad is going to be ovary. So ideally in patients of Kallman syndrome, she is going to be a female patient only. Because the karyotype is 46XX, the gonad, the internal genitalia, the external genitalia, everything is going to be a female organ. But since the hypothalamic failure is going to happen in patients of Kallman syndrome, because of that reason, the LH and FSH is going to be very low. Since it is going to be low, therefore when acting upon the ovary, it will release very little amount of estrogen and progesterone and everything. Since the level is going to be very less, therefore it will bring about hypoplastic uterus, and not just that, it will also cause decrease in levels of androgen. Therefore the pubic and axillary hair is going to be very scanty and the breast is going to be absent, because for the proper breast development we need estrogen, because the breast development is going to depend upon the estrogen. So the breast is also going to be absent in such females. Is that clear? Okay. So what is the ideal differentiating factor from Turner syndrome and Kallman syndrome? So one such differentiating factor in patients of Turner syndrome, which is 45XO, and now we are discussing about Kallman syndrome. Kallman syndrome is ideally 46XX. Is that clear? Yes. So in patients of Turner syndrome, they are going to have a short stature. But in patients of Kallman syndrome, the stature is going to remain normal. So this is one differentiating factor between Turner's and Kallman syndrome. Is that clear? Yes. Okay. So now in patients of Kallman syndrome, there are other associated features as well. So what are those? There could be certain dental anomalies. There could be some hearing issues. There could be problem with color blindness. Yes, and there could also be hyposmia, or there can also be anosmia. So this signifies what? It signifies that this hypothalamus is actually very important for certain development in the body. Okay, so The patient can also have associated features such as dental abnormalities, hearing issues, color blindness, hyposmia, decreased in sense of smell, anosmia, absence of the sense of smell. Everything could be the associated features as well, because for all these functions, hypothalamus is going to be very important. And in patients of Kallman syndrome, the hypothalamus is going to go into a state of failure. So because of this hypothalamic failure, GnRH is not going to be released. So this is the major thing you should have to remember about Kallman syndrome. So just take a note here. So write Kallman syndrome, put equal, and you have to write hypothalamic failure. Hypothalamic failure. And cryptomenorrhea. We discussed in the previous module, cryptomenorrhea. The actual problem is with the imperforate hymen. It's the most common cause. Because of this imperforate hymen, whatever menstruation is going to happen in that female, it will never come out, right? So this is the major hallmark of this characteristic of this syndrome. So while discussing about cryptomenorrhea, imperforate hymen, we're going to create a cruciate incision on the hymen and let all the blood which is going to come out through menstruation is going to come out normally as in every other normal female. But what is the ideal treatment of this Kallman syndrome? So what was the ideal problem in Kallman syndrome? The Kallman syndrome, the ideal problem was with hypothalamus. Okay, now you tell me, what is the thing that is going to act upon the anterior pituitary from hypothalamus? So what is actually needed for hypothalamus? What is that stimulus? What is that one stimulus which is needed for anterior pituitary from the hypothalamus? We all know that that is going to be this GnRH. So it needs only the GnRH. So why don't we give that GnRH now? Instead of the body releasing the GnRH from the hypothalamus to act upon the anterior pituitary, why don't we administer that GnRH? So can we administer that? Yes, we can administer. So the treatment of choice is going to be gonadotropin releasing hormone. And how are you going to give this GnRH? It has to be given in a pulsatile manner. We all know that from the hypothalamus, the GnRH has to be released in a pulsatile manner, and depending upon the frequency, if it is going to be very high or it is going to be very low. If it is going to be low, it is going to be FSH is released. If it is going to be high, LH will be released. So we have to give it in a pulsatile manner for the proper release of FSH and LH from the anterior pituitary. So only if FSH and LH is released from the anterior pituitary, it can act upon the ovary and bring about the release of estrogen, progesterone, inhibin B, and the ovulation can happen. So you have to give pulsatile GnRH. Is that clear? Yes. So pulsatile GnRH you have to administer. So the treatment of choice for Kallman syndrome is going to be pulsatile GnRH. So please remember that any patient with complaints of primary amenorrhea with decreased LH and FSH with the uterus being present, the patient is a case of Kallman syndrome. So how are you going to do the investigation in this patient? So the first investigation, we are going to do the examination in that patient. Alright, so the breast examination and the external genitalia. So the external genitalia is going to be a female external genitalia, and the breast development is going to be decreased or very less, okay, or even absent. And then what are you going to do? Now I have to do the UPT. UPT is going to be negative. I have to do ultrasound. In ultrasound, I can see the uterus. Uterus is present, but still it is hypoplastic uterus in Kallman syndrome, because the estrogen level is going to be decreased, because the FSH and LH which is released from the anterior pituitary is going to be very less. So if it is going to be very less, then estrogen is also going to be released very less from the granulosa cells as well. Is that clear? Okay. So we have done the local examination, breast, external genitalia examination, UPT, ultrasound, and everything. Now when you do the serum FSH levels, it is going to be decreased. So decreased serum FSH and decreased serum LH is the characteristic feature. So any patient, please keep in mind that any patient complaining of primary amenorrhea with uterus present, irrespective of whether it is well developed or hypoplastic, and serum FSH LH level is going to be decreased, then it is a case of Kallman syndrome, hypothalamic failure. Is that clear? Okay. So this is all about Kallman syndrome. So we have discussed everything we need to learn about the Kallman syndrome in this module, right? So let's meet in another interesting session where I'll be discussing about the Turner syndrome. Okay, until then, please keep studying, students. Bye.